Human movement relies on a biological engine that actively bridges the gap between electrical impulses and chemical transmitters. When you reach for a cup of coffee or take a step forward, that action requires perfect synaptic timing. If that transmission fails, movement stops. This blueprint of the human brain highlights the specific engine responsible for that timing, the basal ganglia. Deep within the structure, a neural tract connects the substantia nigra to the corpus striatum. In a healthy system, a steady flow of dopamine molecules travels across this specific pathway. Inside the synapse, that dopamine serves a very specific mechanical purpose. It binds to D2 receptors located on nearby cholinergic neurons. By locking into these receptors, dopamine applies a vital inhibitory brake to the receiving cell. That braking mechanism is strictly necessary because of a secondary neurotransmitter in the system, acetylcholine. Without dopamine holding it back, the cholinergic neurons would release acetylcholine at an uncontrollable rate. Coordinated, fluid motion exists because of this chemical tension. It is the constant, active suppression of noise that allows for a specific motor signal. Parkinson's disease is characterized by the physical degradation of this system. Specifically, the dopaminergic neurons originating in the substantia nigra undergo aggressive neurodegeneration and die off. Looking at this diagram, the immediate consequence of that cell death becomes visible. As the dopamine pathway dims, the inhibitory brake is completely removed. In direct response, the adjacent acetylcholine pathway flares into a state of unchecked hyperactivity. Those hyperactive signals pulse rapidly outward, flooding the receptors on the skeletal muscles. This bombardment forces the muscles into a state of intense, sustained contraction, which manifests clinically as severe muscular rigidity, resting tremors, and uncoordinated movement. Effective treatment requires a dual variable strategy, replacing the missing dopamine while simultaneously forcing the hyperactive acetylcholine pathways back into balance. Achieving that requires a multi-pronged pharmacological strategy. We have to design drugs capable of bypassing biological barriers, blocking aggressive degradative enzymes, and forcefully reapplying the brakes to the cholinergic circuit. The most obvious solution to a dopamine shortage would seem to be a direct replacement. Load a syringe with dopamine and inject it into the bloodstream. But the human body actively resists this. We can track this resistance on a 3-compartment map. When standard dopamine enters the peripheral bloodstream, it encounters the blood-brain barrier. To a raw dopamine molecule, this barrier acts as an impenetrable wall, actively blocking it from reaching the central nervous system. To slip past the guard, pharmacologists rely on a chemical workaround called levodopa. Levodopa is the optical L-isomer of dopamine. That specific stereochemical alteration allows transport proteins to recognize it, pull it through the barrier, and deposit it into the brain. But there is a flaw in this delivery method. The peripheral blood is saturated with an enzyme called dopa decarboxylase. This enzyme's job is to hunt down levodopa and convert it back into standard dopamine prematurely, meaning it gets trapped in the blood, useless to the brain. The solution is a secondary drug called carbidopa. Carbidopa acts as a chemical bodyguard. It floods the bloodstream and sacrifices itself, binding directly to the dopa decarboxylase enzymes to neutralize them, clearing a safe path for the levodopa. Crucially, carbidopa is engineered so that it cannot cross the blood-brain barrier itself. Its inhibitory effects are perfectly isolated to the periphery. This is why the foundational treatment for Parkinson's relies on administering both drugs simultaneously. Levodopa provides the essential raw material, and carbidopa provides the escort necessary to deliver it. Once levodopa safely breaches the central nervous system, local enzymes strip away its disguise, converting it into usable dopamine. But inside the synapse, it immediately faces a new set of hostile mechanisms. The adjacent glial cells and mitochondria house monoamine oxidase B, or MAOB. This is a highly efficient catabolic enzyme that sweeps the synapse, tearing apart the newly formed dopamine molecules before they can properly bind to the receptors. To counter this, drugs like selegiline and razagiline are deployed into the brain. These are MAOB inhibitors. They seek out and lock up the catabolic enzymes, halting the degradation process and forcing dopamine levels to accumulate inside the synaptic cleft. The medical distinction here is highly specific. These drugs must be selective inhibitors that only target the B variant of the enzyme rather than non-selective inhibitors. This split screen illustrates why. The gut relies on a variant called MAOA to metabolize tyramine, an amino acid found in aged foods like cheese. If a non-selective drug blocks MAOA in the digestive tract, dietary tyramine escapes into the blood, triggering massive spikes in norepinephrine and causing a potentially fatal hypertensive crisis. By utilizing selective inhibitors, medicine actively defends the vulnerable dopamine from the brain's internal recycling system without shutting down the digestive tract's necessary metabolic defenses. We also have to account for an enzyme called COMT, which degrades neurotransmitters in both the peripheral blood and the central glial cells. Physicians often introduce a third layer of defense, utilizing COMT inhibitors like entacapone to suppress the secondary threat. These interventions rely on a finite biological resource, surviving dopaminergic neurons. As the neurodegeneration progresses, the cellular factory physically disappears. Even with an abundance of levodopa available, there are no cells left to convert or release it. Returning to the synapse, we can see the alternative approach. When the presynaptic neuron is too withered to function, we use direct dopamine agonists like ropinirole. These synthetic molecules bypass the dying neuron entirely and physically lock into the postsynaptic D2 receptors themselves. Once the agonist manually trips the D2 receptor, the downstream effect is immediate. It removes the inhibitory block on the thalamus, allowing clear, uninterrupted movement signals to finally reach the motor cortex. Physicians can also deploy amantadine, a compound originally developed as an antiviral, which acts as a chemical facilitator, mechanically forcing the surviving neurons to secrete whatever minimal stores of dopamine they have left. When the biological assembly line is broken beyond repair, pharmacology simply steps around the ruins and presses the physiological buttons directly. Addressing the dopamine deficit handles the lack of motor initiation, but we still have to neutralize the second half of the pathology, the massive, damaging overabundance of acetylcholine. Within the cholinergic synapse, the unchecked acetylcholine rapidly floods the system. The sheer volume of molecules continuously bombards the target receptors until they undergo desensitization. The receptors effectively turn off, locking the skeletal muscles into the rigid, frozen states characteristic of the disease. To solve this, doctors administer central anticholinergic drugs, such as benztropine. This is a blunt force mechanism designed to forcibly reset the system. The drug molecules navigate to the synapse and act like physical shields. They cap the cholinergic receptors, blocking the excess acetylcholine from making contact. Denied the constant stimulation, the receptors reset and smooth muscle contraction is restored. Restoring motor control requires addressing both sides of the equation. We accelerate the dopaminergic pathways while forcefully applying the brakes to the cholinergic system. But artificially dictating neurotransmitter levels across the entire body, forcing the intricate biological machinery to operate outside its natural parameters, demands a steep physiological toll. The side effects of levodopa are logical extensions of its mechanism. High dopamine hyperstimulates gut receptors, causing nausea, while excess signaling in muscles triggers involuntary writhing called dyskinesia. Neurologically, dopamine agonists hyperactivate D2 receptors in the frontal lobe and visual cortex, triggering hallucinations. The drugs also destabilize the brain's sleep architecture. Retaining dopamine via MAO-B inhibitors keeps the brain highly stimulated, resulting in severe insomnia. Conversely, the direct agonists can cause patients to fall asleep suddenly and dangerously in the middle of the day. Some side effects are visually alarming but physiologically harmless, such as the dark red and brown urine discoloration caused by levodopa and COMT inhibitor breakdown. These are not allergic reactions. When you flood a delicate biological network with a chemical fire hose, the resulting chaos is the consequence of pushing the system too far in the opposite direction. The collateral damage extends to the drugs used to combat muscle rigidity as well. Anticholinergics block acetylcholine peripherally, shutting down the parasympathetic rest and digest protocol. The results map directly. Salivary glands fail, causing dry mouth. Bladder muscles lock, causing urinary retention. The GI tract halts, leading to constipation. And the eyes lose focus, blurring vision. Treating this disease is an ongoing, impossible balancing act. the physician is constantly weighing dopamine replacement against acetylcholine suppression, continually adjusting the dosages as the underlying neural circuitry degrades out from under them. These complex chemical interventions do not reverse the pathology. The dopaminergic neurons will continue to die. Yet, by understanding the precise mechanics of the synapse, science has built a system to completely override the brain's failing hardware. Neuropharmacology in this context isn't about finding a cure. It is about meticulously managing chemical decay, adjusting the dials and levers of the human nervous system to extract years of functional, independent life from a deteriorating machine.